Hello, everybody. Hello, CJ. We're just going to wait a couple of minutes before we get started in case anybody else wants to join us. But can everyone hear me? Yeah, okay. Thank you. All right. Okay, we're still just going to give everybody a couple minutes to join, but we do have CJ ready to go. I just wanted to say a quick reminder that all of these are recorded, and after all the lecture series are presented, we will have them on our website. We won't be placing them on the website until the end of the month or so, probably sometime in December. But once we do have those up, I'm just going to send a blast email out to everybody who's been participating in the lectures, and they'll have access to all the lectures that we have done previously and in the future. After CJ next week, we have our registered dietitian, Michelle, joining us on Monday, and also our radiation oncologist, Dr. Erickson, on Wednesday. If you're interested in those, feel free to sign up. If you're not already signed up, it's the same link you used to sign up for this one. But other than that, I'll let CJ take the floor.
Thank you. Hopefully everybody can see my screen and there we go. I can pull up the rest of it. I'm
I can't hear
CJ
you,
Chris.
Christian or CJ.
You can't hear me? Can you hear me now?
Yes.
I'm getting some, okay, great. I'm one of the genetic counselors at Fredert and the Medical College of Wisconsin. I specialize in adult oncology genetics, which really encompasses patients with and without cancer, but who might have a concern for hereditary predispositions, and I'll describe that a little bit better here. But I'm one of a team of six, maybe, genetic counselors who are involved in cancer genetics. Some dabble into other areas, but I have found a little bit of an extra niche in pancreatic cancer, though I do see patients for a variety of different cancer indications. So um, happy to be chatting. This is my second year, I think, doing this talk. So happy to see um, people joining here. Um, as it happens, today is Genetic Counselor Awareness Day. I don't know that I realized that when I picked this day, but it worked out very nicely. So, there's a little definition of genetic counseling for those who might not be as familiar with what it is, but altogether, we are providers that specialize in helping people understand both medical and psychological implications to genetic information. And most people who come for genetic counseling will be undergoing some discussion of genetic testing. But really, the process of genetic counseling is a shared discussion and decision making around genetic information, and then the processes after testing, family risk, all of that. So when we think about cancer genetics, there is more of a focus on personal and family histories of cancer to help discern if there is a suspicion, talk about testing, and understanding risk for cancer. Um, I do like to put out there, some people have the misconception that we're a type of physician. We're actually not. There are some genetic counselors who have a doctorate. If they decide to do research, they might have a PhD, but and there might be some medical doctors who have gotten a genetic counseling degree or vice versa. So that does happen from time to time, but for the most part, genetic counselors are master's trained, following a bachelor's degree in some major, which can vary greatly. So just so you have a little bit of an idea of the background. And then for the most part, we're board certified, and depending on the state, licensed as well. Wisconsin does currently, as of late last year, have licensure. Um, so I'll circle back to what the genetic counseling appointment might look like, but most people that come for genetic counseling are they're kind of the first thing at the top of their mind is the testing. I'm coming for testing. What am I doing? All of that. So I'll talk about that for a little bit here. Genetic testing can be done in many fields. In the cancer field, we are analyzing genes, which are the genetic codes that really everybody has, to look for mutations, more technically speaking, harmful mutations, or sometimes on a report that tests that somebody might have as a positive test for a mutation, it might say pathogenic or risk increasing or deleterious, just depending on the timing of the test and the lab that did it. But we're looking for those mutations that can prevent the genes from functioning properly. So a couple of the genes that people have most commonly heard of are the BRCA genes, BRCA1 and BRCA2. Historically, those are very much associated with hereditary breast cancer, and ovarian cancer, but have also become very much genes that we look at in pancreatic cancer as well, as well as other cancers like prostate. And those are not the only ones. I'll show some other examples in just a minute. But when we're doing testing, we're really analyzing these and other genes to look for those mutations. So when you talk about giving a sample, so like at Freighter, we commonly do blood, some people do saliva. I have an asterisk there because that is the most common for standard samples. There will be exceptions. So for people who might be affected by hematologic malignancies, especially those that are not in remission, and those would be what you might think of as the circulating cancers like leukemias or lymphomas. Sometimes those can cause need for other samples or for people that have history of receiving a bone marrow transplant or a stem cell transplant for one reason or another. If you have somebody else's DNA in your bone marrow, we can't use blood or saliva. There are other options in those cases, so that's why I have an asterisk there. But those are the most common samples that we're typically getting for people doing testing. And then what the labs will do, there are very special labs that do the genetic testing. They are extracting the DNA. The DNA is typically found actually in the white blood cells. And they will extract that and they will analyze the genes that we would like them to analyze, basically. So in cancer, people might have several to many cancer genes assessed, something like that. There are many general reasons why this is useful for patients with various cancers, but especially pancreatic cancer. One of the biggest is treatment. Some oncologists will do a variety of tests, including looking at the tumor genetics. So they look at the cancer cells for changes that could impact individualized treatment and target that. Same with hereditary testing. So hereditary testing isn't just, we're not looking at the cancer cells, we're looking at the even the healthy cells, the cells you've had from, your whole life and really the DNA you were born with. And sometimes that can also be targeted. So for people that might have a hereditary mutation, depending on the gene mutation, sometimes that can be targeted by an oncologist. So this is information that, if we do testing with a patient, we will often send that information back to the oncologist to discern if there is anything that's going to alter what they're doing. I sometimes describe to patients as this is your oncology toolbox. If you have extra tools in the toolbox for your oncologist, it doesn't mean they have to use them, but they have them available. And so that's kind of the way I think of it. Um, for others, it might be more of a way to find an explanation. So people who have cancer, do they have a hereditary predisposition that put them at higher risk all along? And sometimes family history, does it match also what's in the family history? For people with and without cancer history, this can also be information used to understand future risks. So part of the hereditary mutations is that they don't always guarantee cancer will occur. So we do see people with high, moderate risk mutations, anywhere in between, that kind of live through life without actually developing cancer, but being at higher risk is something we still want to focus on. And so sometimes we will talk about other screenings. So not just understanding the future risk, but how to manage that risk. And that can be both for people with and without cancer history. Risk reduction in certain cases. So if, again, kind of if I use the BRCA genes as an example, some people may hear about friends or family with BRCA mutations who complete double mastectomies to reduce the risk for breast cancer, something like that. And last but certainly not least is when there's genetic testing of this sort, the hereditary testing can be informative for family members. We see that mutations are passed through the generations and can increase the risk for family members as well. So sometimes we will see family members of those who have tested positive for a mutation. Gets more specific, certainly when we find a specific gene mutation, then we want to tailor things according to that gene. But this gives a little bit of an overview of what we might think about. Um, I kind of alluded to this already, but just again, hereditary cancer is not a guarantee to develop cancer. It is not a diagnosis of cancer. Um, and it may not be the only risk factor. So it is still important to account for the fact that other risk factors in life can still play a role that could include lifestyle, exposures, age, and family history. We do see family clusters of cancer that don't have a hereditary finding, but family members could still be at increased risk. So, um, but we do know that genetic predisposition is in and of itself a risk factor for cancer. So I like to throw this up. This is going to be sort of some examples of the different hereditary pancreatic cancers. So, um, what I will say is that everybody who is diagnosed with pancreatic cancer is eligible for genetic testing and really should be at least offered genetic testing. We have generally seen that for the various cancer types, 5 to 10% of cancers are hereditary, but studies have shown that certain cancers have a higher frequency of being hereditary, and pancreatic cancer has a little bit of a higher frequency, up to 15 to 20%. And that's one of the reasons why we do offer genetic testing for pancreatic cancer patients. The other is just it's relatively uncommon diagnosis compared with some of the other cancers in the average population, like breast and prostate cancers. Um, what you'll see here is, just represent some examples, the BRCA genes, the names in green at the top of each of these. That's the name that is that often goes with the gene mutation. So if somebody, let's say, has a mutation in BRCA1 or BRCA2, we call that historically hereditary breast and ovarian cancer syndrome because those are the primary or biggest two risks that are associated. There are genes associated with Lynch syndrome that are known to increase the risk for pancreatic cancer, and those are also high-risk colorectal cancer genes. And then you'll see some others as well. Um, and then at the very end, I've just for reference, just in case there is anybody with the very much less common pancreatic neuroendocrine tumor, which is distinct from the adenocarcinoma or the exocrine types that originate in the digestive enzymes. The neuroendocrine tumors originate in the hormone producing cells of the pancreas, and there are distinct genes that can be associated with those. So I threw those on there just to kind of highlight that those are some things that we will see and don't want to ignore, though, as I'm sure many people are aware, the pancreatic adenocarcinomas are the more common type of pancreatic cancers. So those are just some examples of the hereditary conditions that when we do a genetic test, unless we already know about a mutation in a family, we are often testing all of these at one time. And sometimes not just the pancreas gene. Some people will choose to do very broad cancer panel testing in contemporary days where we can rule out other things, whether it's family history related or not. So some of the other breast cancer genes or colon cancer, prostate, skin, etc. But typically the motivation for panel testing these days is to make sure we're not missing anything. You can kind of see how many different pancreatic cancer genes there are. And so you could see that if we chose to test, say, BRCA1 and BRCA2 only, we have the potential to miss some of these other ones. And so panel testing has become very commonplace these days. Um, This is really a summary of what I've already gone through, but for those who have pancreatic cancer, these are going to be some of the mainstays of what we discuss with our patients. This is a treatment related focus. We want to see if there's an explanation. In some cases, if we can't understand your future risk, we'll help manage that. And of course, information for your family. Um, for those who do not have pancreatic cancer, so we certainly will see people who may have a family history, it is to understand the family history and determine if there would be any benefit from screening for pancreatic cancer and possibly other cancers as well. And of course, the information for family still applies when we do this type of testing. So that's basically a summary of what typically comes up for people who we see with cancer and those who don't. I do want to come back to the counseling appointment. So usually if somebody is referred for genetic counseling, it means that you're having a discussion first. So you may go over um, personal medical history. There is a family history, which usually encompasses getting what's called a pedigree or a family map, which focuses on cancers. But the pedigree is also designed to get people who don't have cancer in the family so that your counselor can get a bigger picture of suspicions that they might see in your family. And then there's going to be a discussion about what is in your family in the context of what those suspicions are, risk assessment for hereditary cancer, implications from doing that testing, and then discussion of the genetic testing. What are your options? Some discussion about cost and insurance. What are the limitations of the testing these days? What are the benefits, risks, and consent is a big part of that process, making sure that you are deciding as the patient if you actually want the testing. Some people see us and kind of leave wanting time to decide or not wanting testing. We get lots of questions about discrimination in genetics, and so there is discussion about that. Can genetic testing results be used to affect life insurance or health insurance? And so we'll talk about protections that are in place and what some of those limitations are. What results can we get? How are those disclosed to you? Things like that. And it's not just always medical. There are going to be um, some parts of the appointment that might be more of a focus on the emotional impacts of testing and resources and assistance around that and support groups and things like that. But really, as the bottom says, these appointments are designed to really promote patients to make these decisions around testing what is right for you as an individual. And there are many reasons why people may or may not choose testing. It can be a very personal decision. So this is more, for those who might be interested in genetic counseling. There are many ways to get a referral. Some people with cancer may ask their oncologists, those without cancer or who are no longer seeing a cancer specialist may ask their primary care provider. And at least at Freighter, we do accept self-referrals. So I've put that number on here as well for those that really would like to speak to a genetic counselor in more detail. Um, and for those who, may go through other health systems, I will say there are many genetic counselors in Wisconsin. There are most states now have genetic counselors and but if there are any concerns locating a genetic counselor for family members who aren't in state or anything like that, I'm happy to be of assistance. We have a locator, if you will, for finding specialists in certain areas who do both a combination of in-person and video or phone discussions. Yeah, but I don't know, that felt pretty brief to me, but I do like to leave it open for questions that people might have. Is that there's anything I breezed through too quickly or any questions that anybody had coming into it or that you may have thought of? And I'm happy to share my number as well, so that if people have questions later, or just need to know how to get in touch, or anything like that, I'm happy to give my personal number as well. Are there any slides that people want to see again? Otherwise, I'll stop sharing my screen and I can, I'll actually just pop my direct number into the chat here so that people can write it down if you'd like it.
Thank you so much for sharing your contact info.
Mm-hmm.
Again, these slides will be recorded and we will send out a link once they are posted. Take CJ's number down if you have any questions or just any inquiries for him. Otherwise, I think that's good. Then we can end this early and I'll enjoy the rest of our evening. Oh, wait, 1 second. There is a question in the chat. Can you see it, CJ?
Yes, yes. And that was probably more in reference to the BRCA genes. Um, and I can pull that back up actually here for you. There we go. Let me go back there. Oop. Might have to represent here. Give me a second. But that was so the BRCA genes, BRCA1 and BRCA2 are genes associated with hereditary breast and ovarian cancer syndrome. And I'm gonna find that slide here again for you. Hopefully that's better there. So uh, individuals who have a BRCA mutation um, are most for females, the highest risk is breast cancer, but what we do see is those represent moderate risk pancreatic cancer genes, so there is some increased risk. Um, all the genes you'll see here carry different risks for pancreatic cancer, so it's actually Putz-Jaeger syndrome, the STK11 gene you see here, people with CDKN2A mutations, the one just to the left, actually have higher risks for pancreatic cancer than they do with a BRCA1 or 2 mutation, but BRCA1 and 2 genes are more commonly found to have mutations. And those are ones that tie with breast cancer risk as well. There are a couple that you'll see over toward the right, the PALB2, PALB2, and ATM. Those don't have really syndromic names, but individuals with mutations in one of those two genes are predisposed to breast cancer. And then pancreatic cancer is another one of the main risks. PALB2 does have a little bit more ovarian cancer association as well, but pancreas and breast are a couple of the bigger two. Yeah. Sorry, do you have a question?
Yes. So with this, let's see, 1, 2, 3, 4, the sixth one over hereditary breast and pancreatic cancer predisposition genes. What about prostate cancer? What are, is there a determining mutation to a certain gene beside the BRCA gene that could predispose someone to prostate cancer?
Yes, there are. And the BRCA genes are prostate related. Uh, I haven't put the prostate necessarily, like a prostate panel might look a little different. There will be some overlap, but yes, prostate cancer can certainly have certain genetic predispositions behind it. Um, uh, with variable risks depending on the gene, just like pancreatic cancer genes. We do tend to be a little bit more concerned about hereditary prostate cancer if there are maybe a handful of men in a family with prostate cancer, if there's anybody with a metastatic prostate cancer, um, or if somebody goes to a provider and they're told that they have a high risk or very high risk prostate cancer, we tend to get a little bit more concerned that that's hereditary compared with a low stage prostate cancer. So that is actually very different than pancreatic cancer, where it doesn't matter the stage of pancreatic cancer. But yes, the short answer is yes, there are genetic predispositions for prostate cancer frequently tested with panels. So for people that are doing very broad panels these days, it often will include pancreatic cancer genes, prostate cancer genes. Um, but there can be some different ones that aren't highlighted on here.
The reason I ask is my husband had both pancreatic and prostate, and I wondered, but I believe his BRCA genes are not involved in the pancreatic cancer, but it's conceivable that they could be with the prostate.
Well, so if he had, genetic testing that looked at the BRCA genes and those were normal, then that applies as kind of, those genes have been normal his whole life.
Right, okay.
It is true that people with different primary cancers, each cancer can have different tumor mutations. So cancer is a genetic disease. It is actually going to occur because we accumulate mutations over time. They're not always hereditary, meaning we're not always born with them, but if a single cell goes awry in a lifetime, that cell, if it doesn't go through the normal process of fixing itself, it can then snowball into cancer. And so a pancreatic cancer itself can have certain tumor mutations that are just in that cancer. They're not in the healthy cells necessarily. And a prostate cancer, different cancer, could have different tumor mutations. So that is the case. So you can certainly see people that have, say, a BRCA mutation in their tumor that may be in one cancer but not in another cancer. That can happen. But usually if somebody has a normal BRCA testing, especially with today's technology, that's normal on hereditary testing, that's going to be normal regardless of whether somebody has other cancers or not. Yeah, good thoughts, questions. Any other questions? I see there's more in the chat here, sorry. Is genetic testing the new technique to cover? Okay, so if I'm understanding the question correctly, is that you mean to look at like everything genetically, even outside of cancer, or just cancer? Is that the question, if you're able to?
Does the new genetic testing technique cover most of the cancers like pancreatic, breast cancer, or genetics, or like BRCA and all those things? Yes.
Yes, I would say the bulk of genetic testing being done now is large panel testing, which often will look at a broad variety of cancer genes. So, people are sometimes might be the only one in their family to have pancreatic cancer, and they may still be getting a panel that looks at a variety of other cancer risks, prostate, kidney, skin cancer, etc. It is more commonplace. It is not, some people don't want that much information, so it's not that everybody will do large panels, and it does vary depending on the clinic and the clinic practice. But yes, that is more commonplace now to be very broad in testing. Yeah.
I had one more question. I'm sorry.
Yeah, go ahead.
I think I understand what the answer to my question could be, but I'm still curious to know. The tumor sample that was taken at the time of my husband's surgery,
Mhm.
You obviously have written results, but is that specimen or whatever it's called, is that kept in a lab in a state that future testing could be done on that sample if other types of tests occur or are developed?
Oh, that's a great question. Largely outside of my scope, but to my understanding, Tumor specimens are typically kept by the pathology office or department that runs it for so many years. Some states require they be kept for so long, say a decade, and then they may be discarded, but it could vary. Some could be kept longer depending on the requirements of a state or a facility.
And the same applies to the blood sample that was taken. There's no possibility for further study past the time that the initial testing was done.
So blood sample, it depends what the blood sample is for. If it's for research projects might have protocols to dictate how long those samples can be maintained. I will say sometimes with our hereditary testing patients, if they want to bank a sample, sometimes we have a team that's able to keep that sample indefinitely, and unless we're told to get rid of it. But it just depends on what the blood sample is for. That might dictate how long it can be kept for. But as long as they're housed to be viable, in theory, they could be kept for a very long time. Yeah. I do see other questions here. So Susan, you were asking about the 6th rectangle and breast cancer with no BRCA mutation, but pancreatic cancer as well.
Right, yes.
Yeah. And that does happen. Some people do have no mutations found and unfortunately develop future cancers. And I think that goes back to, well, there are some possibilities. Were you tested for other genes, some of these other genes? Do you recall? And I'm happy to talk with you individually if you're more comfortable with that. You're muted if you're
Yeah, Sloan Kettering has done an awful lot of testing on mine.
Okay. Yeah, there are many possibilities when we think about that. We know that people without hereditary mutations can still develop multiple cancers, still at risk for cancer, whether it's one or multiple. Sometimes I will blanket statement this, but genetics is a constantly evolving field. We are learning about new genes that are linked with cancer. Our technology advances, we might be able to detect additional mutations in the genes that we know about. So to put it in perspective, I will see patients who had BRCA testing 10 years ago. The technology has changed to catch more mutations. So they have retesting of those and other genes to catch up with the technology of the day. So sometimes people have normal testing and it could be that we can't rule out a mutation because of genes we haven't discovered, limited technology, things like that as well. So that's where it can be important to keep in touch with your treating team every so often to check on those advancements. Yeah.
Is
And
there
then I
any
did
kind of-
see, go
yeah.
ahead.
Is there any kind of, I was diagnosed with the KRAS mutation, which I understand is pretty common for pancreatic cancer.
Yeah. KRAS is a
It's all
gene.
Greek to me.
Sorry, what was that?
And it's all Greek to me.
Yeah, KRAS is a gene that is tested commonly in tumors. It is not a gene commonly tested on a hereditary side of things because it is common to see that gene mutation. And there are other mutations in certain genes that might be more frequently needed in the tumor, but not something that is tied with hereditary risk. And so that's why we don't test it in hereditary testing. But those are still genes that can play important regulatory roles in the cancer cells. So if they're not working in the cancer cells, they can be targeted by certain treatments if they are in the tumor. Those are not the only ones. There will be many others that can be looked at that are sometimes only on the tumor side and not tested on the hereditary side. And then there are some that could be both tested both in the tumor and hereditary. An oncologist might be better able to speak to some of the targeted treatments they will look at for those genes that are in the tumor only, the tumor only testing. But that's not something that is typically going to be hereditary.
Can the KRAS mutation be found in any other cancers other than pancreatic?
Yes, I have seen it in other cancers. Off the top of my head, I don't want to speak wrongly. Again, I think that might be better directed to a medical oncologist, in fact, or a surgical oncologist. But yes, I have seen it. So sometimes a genetic counselor, like what I will do is I will review a tumor report to see if there are findings that we also want to look for when we do a hereditary test. For example, have a BRCA1 mutation in a tumor, and if it is at a frequency in the tumor that's concerning, we might be concerned that it originated in what we call in the germline, or the cells that you were born with, and then it showed up in the tumor, because if your healthy cells have it and a healthy cell becomes cancerous, then the cancer cell is expected to have it. So we do look at tumor reports to make sure that, you know, we're checking the appropriate genes when we do a hereditary panel. And yes, KRAS can be something that's found in other cancers as well. And then I do see, Jean, your question about RAS and KRAS. That's probably about as in-depth as I can go on those genes. I think those will be better addressed to a medical oncologist, but hopefully that gives a little bit of an intro or spectrum from hereditary physicians. But any other questions around that? Well, if there aren't other questions, like I said, you feel free to reach out to my number, or if you ever want to schedule an appointment at Freighter, that number was also there.
Thank you so much.
Yeah, my pleasure. Thank you for having me this evening.
Thank you.
Take care, everybody.
You too.
You too. Good night.